Hey, I'm Zatisha, and this is Jada, and we're going to be talking about masticatory muscle disorders. Okay, students will learn about what causes masticatory muscle disorders, its signs and symptoms, likely functional limitations, and how it's tested and measured. Students will also learn the different differential diagnosis, rehabilitation processes, and we will end it with listing some outcomes and giving a brief overview. Okay, so what is it? The masticatory muscles included in this is the masseter, lateral pterygoid, temporalis, and medial pterygoid. And this is just when muscles, it can be directly or indirectly injured, or directly through overuse and tensile strain, or indirectly through muscle guarding and centrally mediated myalgia, which that is just a process that involves chronic overactivation of the muscles. There may be a presence of TOMP, myofascial bands, and trigger points, which may progress to tendinitis. Pain may or may not cause limited mouth opening, so there's just some muscles you will see they won't be able to open their mouth fully, whereas I think it's only the lateral pterygoid where they can fully open their mouth, but it'll be pain in the end. If masticatory muscle disorder occur in isolation, tests such as palpation, accessory motions, and compression will not cause pain or provoke any symptoms. But if it's combined with another TMJ disorder, those tests will provoke symptoms. Okay, some pathomechanics. They have trauma, occlusal imbalance, which is just an unequal distribution of forces during biting or chewing. Changes in the vertical dimensions, such as like alteration in the space between your teeth. Immobilization, prolonged dental procedures, chronic teeth clenching, diseases, and parafunctional behaviors, which is just like habits such as teeth grinding, jaw clenching, or chewing on objects like pencils or straws. Okay, so when it comes to the masticatory muscles, they can be isolated and present with like localized pain. So for the masseter, muscle spasms may project to the eyebrow, maxilla, anterior mandible, and upper and lower molars. The patients will also experience pain at the end range of opening their mouth. The lateral pterygoid spasms may cause a deep ache in the cheek, maxilla, TMJ, or the ear, and they will experience pain when chewing. And this is, like I said earlier, the only one where they can fully open their mouth. Temporalis, referred pain may extend over the temporal region to the eyebrow and the upper teeth, and to the maxilla and the TMJ, and the patients also may feel pressure behind the eye or have increased eye fatigue and experience headaches. And then the last one, the medial pterygoid, may refer to pain behind the TMJ, deep in the ear, to the tongue, and then back to the mouth. So it travels. Okay, some more clinical manifestations is jaw joint noises like popping or clicking, pain at jaw joint or masticatory muscles, irregular or limited range of motion in neck, and sometimes they may experience some neck and shoulder tenderness. And functional limitations could be things like difficulty chewing, limited ability to open mouth, jaw stiffness, and altered speech.
Okay, so for tests and measures, the first thing that we always want to do is palpate the affected area just to see if the patient has any abnormal muscle bellies, any tenderness, or anything going on with the affected site. We want to do the screen of the trigeminal nerve, which we know is both motor and sensory, so we're going to test both aspects by doing the sensation testing with the cotton ball. We'll just follow all of the branches of the trigeminal nerve, which there are 3. We'll follow all of those just to make sure that there aren't any abnormalities with that. And then we will do the motor portion, which will be tested with the jaw jerk reflex. So this is where the patient will have the jaw in a rested position, basically the mouth open, and then the therapist will place their thumb on the chin and then hit the thumb with the reflex hammer. And then a positive or normal response will be closing of the mouth, and if it does not close, we know that there's some type of abnormality within the trigeminal nerve. Here we can also do manual muscle testing of all of the masticatory muscles that Z mentioned earlier, just to test the strength of those. We also do range of motion testing, opening and closing the mouth to see if we can visually see any deficits. Also, we can do lateral deviation, protrusion of the jaw, just to make sure that they're not struggling with those movements either. And then you can do the power stroke, which is just another muscle strength test. And basically it's testing the masseter and the medial pterygoid, and also sometimes the temporalis muscle. And so we would just palpate here to see the extent of the contraction that the masseter muscle is getting. And then we use MRIs. MRIs are the most used form to test these disorders, just because it's soft tissue and you'll be able to see any deformities with that. Right, for differential diagnosis, so there are a few conditions that can mimic MMDs, but we went with dental absent, or we went with a dental condition and a neuropathic condition. So with the dental condition, it's a dental abscess. Here the location of the pain will be the affected tooth, and that is a way that you can differentiate that from the MMD. Also, the patient would experience intermittent dull or sharp pains. This will also be aggravated by a hot or cold stimuli. And another tell-all tale for this condition will be the visible decay on the affected tooth. For the trigeminal, or for the neuropathic condition, this one was trigeminal neuralgia. And here you would have a deficit in the trigeminal nerve on one side of the face. This person will also experience attacks of sharp pain, and here it will also be aggravated by cold or hot stimuli. It can also be aggravated by eating, but the tell-all tale here is the painful light touch. So going into the rehab process, being that this condition varies from patient to patient, the interventions there are a lot of different interventions. But for the most part, here in this phase, we want to make sure that we're just reducing any making sure that we have muscle relaxation. We want to make sure that we increase function, strength, coordination, things like that. So in the maximum protection phase, we will implement low-grade manual techniques, some soft tissue mobilizations, superficially just to assist with that muscle relaxation, and gentle passive stretches. During the moderate protection phase, we will start to introduce range of motion exercises, some isometric opening, as well as protrusion exercises, rhythmic stabilization techniques, and this is also where we start to introduce neuromuscular re-education exercises. And then in the minimum protection phase, this is where we will begin to introduce the coordination exercises. Here we will also do strength and endurance exercises. We will continue with the stretching that we were doing in the previous phases of healing. You can also do ultrasound and electrotherapy, specifically TENS. This has been proven to help with muscle relaxation, and dry needling has also proven to help patients with this condition. So for the outcomes, a lot of people do not necessarily need treatment for this condition. Most people have a spontaneous or just out of nowhere resolution of the symptoms. For the individuals that do receive the conservative treatment though, 50 to 90% of those patients do receive, or they have reported relief after 2 to 4 weeks of treatment. And then if the conservative treatment does not go well, surgical interventions are used for those patients. So for the overview, MMD is the injury to masticatory muscles from overuse, strain, guarding, or myalgia. It can be caused by trauma, occlusive imbalance, teeth dimension changes, immobilization, dental procedures, clenching, or any some other diseases. The clinical manifestations include jaw popping or clicking, muscle pain, limited range of motion, and neck or shoulder tendons. Functional limitations include difficulty chewing and limited mouth opening, range of motion. The tests and measures that are used for this condition are the Chevet sign, the testing of the trigeminal nerve, MRI, or even doing lateral deviation range of motion. Differential diagnosis includes the dental abscess or the trigeminal neuralgia. The rehab process for this condition focuses on pain and muscle relaxation in the maximum protection phase. It aims to restore mobility and muscle control in the moderate protection phase, and focuses on improving strength, endurance, and coordination in the minimum protection phase. And outcomes are 40% resolve spontaneously, 50 to 90 improve within 2 to 4 weeks of therapy, and if the conservative treatment does not work, surgery will be used for unresolved cases. These are our references.